Hello, good morning, everyone. Thank you so much for joining the SPSSI Graduate Student Committee webinar series titled Beyond the Ivory Tower, Bringing Activist Conversations to Academic Spaces. Our second discussion is on understanding sexual and intimate partner violence, contact culture, and pathways to healing. I'm Ebony Gabriel, the Policy and Applied Work Officer of the SPSSI Graduate Student Committee, and I'll be facilitating our webinar today. Any opinions or conclusions expressed in these webinars are those of individual contributors and do not reflect the views of the Society for the Psychological Study of Social Issues, the American Psychological Association, or any of their divisions or subunits. Now let's find out who our panelists are. So first we have Dr. Salime Salim, who is a graduate of the Clinical Psychology PhD program at Miami University. She is a postdoctoral fellow at the Department of Psychiatry and Behavioral Sciences at Stanford University. Her research program investigates sexual violence and associated outcomes through a social ecological lens, with a particular focus on sexual minority women's experiences. Our second speaker will be Dr. Chiara Sabina, who is an associate professor at the School of Social Work at Rutgers University. Her research centers on interpersonal victimization, especially intimate partner violence, sexual violence, and dating violence among Latinos. Dr. Sabina employs a contextual strengths-based perspective with respect to interpersonal violence, focusing on understanding groups, the influence of cultural variables, help-seeking responses, and examination of the service delivery system. Our third speaker is Dr. Sherry Hamby, who is a distinguished research professor of psychology at the University of the South and director of Life Paths Research Center. She is also the founder of Resilience Con. She is an internationally recognized authority who is known for her work in poly-victimization, violence measurement, and resilience. So now I will hand it over to our speakers. Our first speaker up is Dr. Salime.
Thank you, Ebony, for that introduction. So let me get us started by sharing my screen. Is everyone able to see that okay? Yep, awesome. Thank you. So I will jump in today. I'll start off by talking more broadly about the scope of the problem of sexual and intimate partner violence in the United States specifically. Then I'll review some specific rates in the LGBTQ community and move into a discussion of specific risk factors for negative recovery outcomes among bisexual women. So kind of to start off with understanding rates of violence in the US, these are some data that come from the CDC's National Intimate Partner and Sexual Violence Survey from the years 2016 and 2017, show that experiences of sexual violence are common among women and men, with 1 in 4 women reporting a completed or attempted rape during her lifetime, and 1 in 9 men reporting being made to penetrate someone else during his lifetime. Kind of when we also look at other types of victimization and include things like sexual coercion and unwanted sexual contact, the rates of lifetime contact sexual violence become higher, with a prevalence of kind of over 50% among women and about 30% among men. And in contrast to typical rape scripts and what we might often see portrayed in the media or kind of news, the sexual violence is most often perpetrated by someone that is well known to the victim. For example, in the same national survey, found that about half of rapes were perpetrated by acquaintances, which include in that category included friends, neighbors, coworkers, classmates, etc. And among female victims in particular, intimate partners were also kind of the perpetrators for about 40% of the rapes reported. Stranger rape does occur, however, at a much lower prevalence. It's about 12% among female victims and 14% among male victims. And now kind of moving into some information about intimate partner violence from that same national survey. Rates of intimate partner violence are also common among both women and men. And intimate partner violence here includes sexual, physical violence, as well as stalking victimization by an intimate partner. And kind of again, when we look a little bit more closely at these types of intimate partner violence, we see that physical violence is the most common form of intimate partner violence, with 42% of both women, about 42% of women and men reporting a lifetime experience of physical violence from an intimate partner, followed by about 20% of women reporting contact sexual violence by an intimate partner. And these high prevalence rates of violence are alarming because sexual and intimate partner violence are detrimental to survivors' mental as well as physical health, but I'll be highlighting some of the mental health outcomes here. There's a large literature demonstrating that these types of violence increase the risk for post-traumatic stress disorder, or PTSD, depressive disorders, anxiety disorders, eating disorders, substance use disorders, as well as risk for suicidality. For example, reviews and meta-analyses of the literature on sexual violence in particular have shown that survivors have a lifetime prevalence of these mental health outcomes that is over 2 to 5 times greater than what we see in folks that do not have histories of sexual violence. Importantly, though, experiences of violence are shaped by power and privilege, which results in heightened risk for victimization among those with marginalized or minoritized identities. For example, rates of lifetime sexual violence and harassment are higher among sexual minority women compared to heterosexual women. And these rates are especially high among bisexual women, with nearly 80% of whom reporting an experience of contact sexual violence in their lifetime. And these are data, again, from that same kind of national survey conducted by the CDC. And similarly, among men, sexual minority men report a higher lifetime prevalence of sexual contact sexual violence, with over half of gay and bisexual men having kind of experienced contact sexual violence in their life. Report of the 2015 US Transgender Survey also indicates that rates of sexual violence are high in the trans and non-binary communities also. For kind of specifically, kind of when we look at all trans and gender minority folks, about 50% report a lifetime experience of sexual violence. And what I've highlighted there is that the prevalence is particularly high among non-binary people assigned female sex at birth and trans men. The full report of the 2022 trans survey has not been released yet, so we do not have more updated numbers for the gender minority communities in the US. And now to shift gears to talking a little bit about bisexual women's experiences of sexual violence and mental health, which has been a focus of my work specifically. Consistent with what we see with the higher rates of sexual violence in this population, we also see that bisexual women experience disparities in mental health outcomes, with the higher prevalence of past year PTSD, mood disorders, anxiety disorders, alcohol use disorders, and suicidal thoughts compared to heterosexual and lesbian women. And these data, again, are all from kind of nationally representative samples in the US. We see, an elevated risk of all of these mental health outcomes among bisexual women. And the elevated exposure to violence and the higher rates of, mental health, negative mental health outcomes within LGBTQ communities is explained and understood through the lens of minority stress and stigma theories, which indicate that sexual and gender minority people experience added chronic minority stressors and stigma due to their minoritized identity that then contributes to these negative health outcomes. Some of these experiences of minority stress include discrimination, microaggressions, hate crimes, expectations of rejection, as well as the internalization of stigma. And stigma theories also highlight the role of stigma at the structural level. So this is referring to laws, policies, and cultural norms that constrain the opportunities, resources, and well-being of stigmatized groups as an important social determinant of health. And kind of especially in more recent years, we've seen more research on structural stigma against the LGBTQ communities in particular and how that impacts health outcomes. But kind of applied to this context of, recovery from sexual violence, for example, we can think about all of the anti-trans legislation that is being introduced, as well as passed, that include laws, for example, that restrict access to certain healthcare for trans and gender minority individuals. We can think about kind of as a downstream, effect of that, how that might, one, influence access to, healthcare, but also how it might impact trust within gender minority communities in the medical systems, in mental health systems, and how that might contribute to them not receiving needed care after an experience of sexual or intimate partner violence. And that example speaks to, the fact that survivors, don't exist in a vacuum. We know this, that recovery from sexual violence occurs in the sociocultural context that survivors are embedded in. And it is not only the individual level factors that determine how somebody recovers from an experience of victimization. And although much of our, specifically therapy and mental health interventions are directed at the individual level, we know that survivors' interactions with people in their kind of immediate circles, as well as with medical, legal, health systems, do influence their mental health outcomes and recovery in the context of violence. For example, there's a large literature showing that when survivors disclose, if they receive negative responses to that disclosure of sexual assault, like, not believing survivors or, victim blaming, those things can be detrimental for post-traumatic stress, substance use, and depression following experiences of sexual assault. Similarly, negative experiences with formal systems like law enforcement and justice systems can also be detrimental to survivors' recovery. And so kind of informed by some of these theoretical models on minority stress, on stigma, and sexual violence recovery, my work has investigated how bisexual minority stress and stigma might interact with universal risk factors to influence post-assault distress and recovery among bisexual survivors. I'll just highlight a couple of quick, studies and findings here. In a couple of cross-sectional studies among young bisexual women who had all experienced sexual violence, I've investigated how specific anti-bisexual stigma is associated with higher PTSD symptoms. And one of these studies looked specifically at the relationship between anti-bisexual stigma and post-trauma related cognitions or post-trauma related beliefs about oneself, about other people, and about the world, which we know are kind of well-established risk factors for PTSD following trauma exposure. And what kind of this study found was that anti-bisexual stigma related to higher threat of harm beliefs, which then explained the link between stigma and PTSD symptoms. And some of these threat of harm beliefs include things like, not feeling safe anywhere, feeling that the world is a completely dangerous place, or, avoiding other people because you think they might hurt you. A second cross-sectional study, again with young bisexual women who had experienced sexual assault, I also looked at the role of shame and how unique anti-bisexual stigma might contribute to feelings of shame, which again we know are a risk factor for post-traumatic stress symptoms among survivors. And this study found that shame explained not only the association between self-blame about the sexual assault and PTSD, but also the links between experienced and internalized anti-bisexual stigma and PTSD symptoms. In a more recent longitudinal study, we also looked at the direct effects of bisexual minority stress, both experienced and internalized and anticipated or anticipated stigma, and how that might relate to PTSD symptoms within a kind of 3-month study that included a baseline and 3 monthly follow-up assessments. And we found some interesting results here. This was again with a young bisexual women sample, ages 18 to 25, who had experienced sexual assault. And what we found was that increases in stigma from lesbian and gay people specifically were associated with increases in PTSD symptoms at that assessment when PTSD was assessed. So, and this was a within-person effect, meaning that when women reported more than their average levels of stigma from lesbian and gay people, they also reported more than their average levels of PTSD symptoms. And then kind of at the between person level, we found that on average across the study, stigma from heterosexual people, higher levels of stigma from heterosexual people was related to higher average levels of PTSD symptoms over the course of the study. And expectations of stigma, or that anticipation of stigma, seemed to explain this association between experienced stigma and higher PTSD symptoms. And so, kind of to summarize here, more broadly, some of the takeaways are that sexual and intimate partner violence are common and have broad negative mental health consequences for survivors, and prevention efforts that reduce the rates of victimization, across different groups are necessary to prevent the long-term impacts of victimization. And more specifically, kind of when we look at, unique vulnerabilities within bisexual populations, clearly there's a need for increased research on bisexual as well as other multigender attracted women's experiences. For example, pansexual and queer women who report multigender attractions, who are also reporting kind of high rates of sexual violence. More research attention is needed there. Bisexual minority stress is a determinant of negative health outcomes among survivors. Given the interconnectedness of minority stressors and trauma-related symptoms, adequate assessment of and attention to minority stress is important for case formulation and treatment. And I'll also highlight that it is really critical for our, interactions and interventions with bisexual folks to be affirmative of bisexual identity. And it might be important for, our interventions to directly address bisexual minority stress in treatment. And finally, there is a need for culturally informed sexual violence prevention programming that, is aimed at reducing high rates of victimization in this population. And it's critical to eliminate bisexual minority stress and stigma at a societal level, including things like structural stigma, as well as stigma at the interpersonal and kind of internal levels. So with that, I will wrap up here, and we can continue our conversation with the second presentation.
Great, thank you. Thank you very much for that presentation. It was very interesting. I'm gonna share my screen and hopefully not have any issues. Start my timer here. Hello, good afternoon for those of you on the East Coast, and I hope you're doing well. My name is Shiara Sabina. I'm an associate professor and the associate director for the Center for Research on Ending Violence at Rutgers University School of Social Work. My work focuses on Latinos, and I'm going to start by giving an overview to the population and looking at some of that context to understand why it's important to look at this group specifically. Latinos represent about 19% of the US population, but we are overrepresented in some groups and underrepresented in others that show those dimensions of power that was also talked about in our first presentation. So we are overrepresented in the immigrant population, and the uninsured, incarcerated, people living below the poverty line, and essential workers, and underrepresented in things such as the labor force, Congress, people with bachelor's degrees or above, in films, doctors, and to connect it to the presentation today, violence research. So we have those kind of access and lack of access in certain things to resources. And as you know, it's one of the largest growing groups, and now represents the largest minoritized group in the United States, accounting for 52% of the growth in the population over the last decade. So we have these forms of inequality that pervade the population, and then from my point of view, change how violence is experienced and responded to. So when we talk about the population, I do want to start by saying there's a huge amount of diversity. We're talking about people from 33 different countries, 20 of which speak Spanish. Also the USA, we have immigrants coming from all of these different countries. There's been a change in who is coming as immigrants. Although Mexicans remain the largest group, there are more folks coming from the Northern Triangle of Central America. People come to the United States for different reasons, including political refugees and labor immigrants. And then there's been Latinos here from before the founding of the United States, right, where the border crossed them folks. So we have recent immigrants, we have people that are part of the founding of the country, and there's also a lot of racial mixing in the population due to the history of colonization and slavery. So we and also influences of trade have influenced that as well. There's also indigenous groups, there's Afro-Latino groups, and so this is what we refer to as mestizaje, a mixing. Latinos represent at their core a mixing of people. And so when we study Latinos, we need to take into account these forms of diversity. Bringing it to intimate partner violence research or interpersonal violence research in general, a lot of the research has relied on studying one form of violence at a time, as opposed to integrating the different forms of violence. And people's experiences are integrated, right? They might experience multiple forms of violence, either in childhood, in adulthood, or a continuation of those forms of violence. We know the devastating impact, both psychologically, physically, and economically, and it costs society as well to have these forms of violence at such high levels. Risk factors have been set up according to the socio-ecological model that was also shared, including demographic factors, such as attitudes towards aggression, attachment style, lack of self-control, alcohol or drug use, education and income for the demographic variables. A history of child maltreatment is one of the main risk factors. Witnessing violence and family of origins, relationship factors, including low relationship satisfaction and conflict, and then societal factors such as stress, unemployment, um, neighborhoods in which people live, chronic community disorder, lack of social integration. And so we could really see these larger systems working as well. And of course, this will also be impacted by policies at the national level and or international level that would impact the responses of the community. So as I study a minoritized and racialized population, the way I look at the research is looking at how social positioning of Latinas influence their experiences, both with risk factors and then the dynamics of violence, and how this impacts help seeking. For instance, fear of immigration authorities obviously is going to impact seeking help, let's say from police or hospitals. So another important part to consider, of course, is that there are lots of strengths in the community that have maintained family systems and had in some national estimates, we have lower rates of some forms of victimization than other groups, and factors that could increase resilience post victimization. Okay, I want to bring us to the current study that I am working on, which is funded by the National Institute of Justice, called Understanding Latina Experiences with Victimization, Intersectionality, and Discrimination, which we have abbreviated to LATVIDA. We have done this research in collaboration. I am the PI, but we have done this with researchers at Indiana University, the research branch of Esperanza United, and we also have a partner within the Community Health Outreach Program of Robert Wood Johnson University Hospital here in New Brunswick. In addition, we have a community advisory board that works with different Latina groups, including like domestic workers or farm workers or the LGBT population, that has also supported our work and helped make it much better. So a shout out to them. And the goals of the overall project are here. It's about understanding the interpersonal victimization rates and having a very wide net when we look at that, and looking at how social identities impact victimization, that help-seeking piece, as well as functioning and protective, psychological functioning and protective factors. These are all the different measures that we have proposed, which I could go into if you'd like. Some of those we've changed as a result of the Community Advisory Board input. So we actually garnered a nationally representative sample through Knowledge Panel Latino, which is hosted by Ipsos. And so in that representative panel, they have recruited folks for their sample through address-based sampling, and then recruited from there, offering internet services if needed, so that we could have a nationally representative sample. And so we relied on their existing panel for this, and sampled 2,035 women from that sample. Just to give you some information, some basic demographic information, it's here. Data is also weighted to represent Latinas across the United States. So you are the first audience for these victimization rates. So here we go. We measured all of these forms of violence: physical assault, sexual assault, threat, stalking, witnessed, coercive control, and sexual harassment. We dug down deeper into physical assault, sexual assault, and threat, and that's why they have 3 columns, because for those, we did designate if it happened in childhood or adulthood. The others, we just asked if it happened. So when you look across these various forms of violence, you get a very devastating prevalence rate of 84% of Latina women have experienced at least one of these. And again, this is not a help-seeking sample. This is not a sample that we recruited through community agencies. This is a representative sample. So it really underscores the level of victimization faced by the population. And I wanted to focus the rest of my time on the sexual victimization piece that I've been able to look at more specifically. And here we have an overall sexual assault rate of 37%, or sexual victimization really should be the largest category here, was actual sexual assault, attempted sexual assault, fondling. And then we also added drug facilitated and alcohol facilitated, which I hadn't done in a previous study, in a previous national study. So we added it here, and it did quite increase the rates. This fondling, forced touch is predominantly in childhood, and that's when you see a lot of these behaviors beginning. And for who is the perpetrator, in line with other research, we have people who are otherwise known, relatives as main perpetrators, as well as spouses. That stranger, though not quite as low as some of the rates in the CDC, is not the predominant form, let's say. And also sibling, which sometimes isn't broken out, but that's also an interesting point of data there. Yeah, okay, sorry. I also wanted to share with you the age of onset. So some of these, like I said, the fondling was the youngest, and attempted unwanted sexual activity, and the drug facilitated, these are later on in the developmental span. I'm going to do a lot more analyses to look at the effects of acculturation, immigrant status, and discrimination, which is also measured. But for now, I did want to share with you the differences between US born and immigrants on the sexual violence indicators. And in line with previous research, we actually see immigrants reporting lower rates of victimization. That doesn't mean less complications once they have the sexual victimization, but as far as rates, they are lower, except for the drug and alcohol facilitated sexual assault. So I thought that was also an interesting finding there, that they're equally at risk. There is no immigrant paradox there when we look at the drug facilitated. And in line with this idea that we must look at victimizations together, we have sexual victimization in childhood, increasing the risk for childhood physical victimization and childhood threat victimization, as well as sexual victimization in adulthood, being related with increased risk for, quite pronounced increased risk for adulthood physical victimization and adulthood threats. Another way to look at this is just overall, not paying attention to childhood or adult, so we could include those other forms that didn't have that. And all of these are significant risk ratios, so that any sexual victimization is associated with increased odds of having the other forms of violence, and the most pronounced being physical and threat victimization. Now, help seeking. We asked about, I'm going to wrap it up here because I see I'm at almost 15 minutes. For help seeking, we asked about formal including police, court, social service, and medical. And then we asked about informal, anyone else in their lives they talked to about this. For sexual violence victims, only 25% of them sought any form of formal help seeking, and 54% sought informal help seeking. This is actually lower than for the other types of violence that we measured, meaning that there's something specific about sexual violence as opposed to physical violence, or trafficking was another one we asked about, that limits people's willingness or ability to seek help. And this was for all the formal sorts of help, in addition to the informal sorts of help. So people are more reluctant to reach out when it's sexual victimization. So the key points of what I've been saying, that these are complex experiences. We need to look at them in tandem. We need service providers to be equipped to deal with the range of victimization experiences. We need to start early. We need to think about perpetrators and educating people about who perpetrators could be. And that's also another implication, help seeking wise, is that those 54% that are talking to someone, how can we educate friends and family to respond in helpful ways? So I will wrap up with that. And I look forward to hearing from Sherry and then having a discussion. Thank you.
Thanks, Shiara and Salime too, for a great presentations that I think will go along well with mine. Is the screen set up the right way? All right, I knew that Salime and Shiara were going to be doing a great job of laying out the scope of the problem, and I think what they have talked about, both in terms of just the overall extent with, more than 80% in Chiara's sample experiencing some kind of victimization. And also, as both of them talked about, like some populations being more vulnerable than others, that does present, it's a very grim picture of how much victimization is out there. And of course, I want to acknowledge that includes those of us who are here on this webinar today, too, that very few people go through life completely unscathed by any kind of victimization and trauma. But I want to shift gears now and talk about healing pathways and resilience and what people can do about that. And I first want to talk a little bit about, when probably all of you have heard that term resilience before, but we often use that in a way that really kind of emerged out of 20th century research from the 1970s and 80s. And it has been really problematic because the way that we often talk about resilience is really not what the current evidence suggests is what resilience is really made up of. But a lot of times when we talk about that term, we just think of it as being a synonym for like emotional toughness or grit or something like that. But that really, it's not just some inherent personality characteristic. And there's a lot of problems with that. And, not least of which is it suggests sort of a one-size-fits-all approach to a lot of problems. But I think that most of us actually have a lot of deep knowledge about how you can recover from even considerable doses to trauma, as both previous speakers showed or comment. And I wanted to actually give us all a chance to learn from each other even here today. So I have created a little Mentimeter word cloud. So if you can either go to this QR code, or if you can go to this link here in the chat. I will also, oh no, I don't know if I can put it in the chat, but I'm gonna switch over to that, and you should be able to get to it either by going to menti.com and putting this code in, or by going to the QR code. And just thought we would take a moment to see what kinds of things help all of us thrive after experiencing adversity or trauma. Here we go. We're making a nice word cloud here. And just give people a few more seconds to type something in. Nice. These are great responses that are coming in. Oh, Tetris. That's funny. That's a good regulatory strategy. I mean, basically, I love to do this word cloud because it really shows that probably everybody on this call already knows what most of what I'm going to say, which is basically that it takes a range of different things, and that many of these, far from being, things like grit or some kind of personality characteristic, are part of the social ecology, that same social ecology that Salime and Chiara were both talking about, can be forces for healing too. So support, social support, friends, close friends, therapists, abolitionist community. I mean, there's some great responses here. There's, also some meaning-making things in here with spirituality and faith. There are, some things like Tetris, which he suggests to somatic work, to working on regulation. And what we need to do, I think, is take this wisdom that is already out there and get this more to be a central part of how we are working with survivors, because I think a lot of times we don't uh, we don't take this wisdom that we know from our own lives and the lives of our loved ones and integrate it into pathways to healing. And healing is actually the most common outcome after trauma. So although PTSD and the other negative consequences that Chiara and Salime were talking about are very serious and they're massive public health problems, I think it's also important to acknowledge that, in fact, resilience or thriving or achieving some level of well-being is the most common outcome after even high doses of trauma of the sort that Chiara were talking about. And I think it's really important that we communicate that message to people too, that they're not doomed to a life of like PTSD or depression or other kinds of problems, even if they've experienced IPV or sexual assault or some other kind of victimization. And as you've already shown in that beautiful word cloud you just created, we now know, and really almost, even though the way we often talk about it in the general public or in the media is very 20th century, all the contemporary work on resilience generally focuses it on being a process that involves the entire human ecology. And my colleagues and I use this term called resilience portfolios for this, and we focus on 4 domains to help organize the kinds of things that have been shown over and over again to help people be able to thrive and achieve well-being even after experiencing different kinds of intimate or sexual violence or other times. Most of these strengths that help people are not specific to a single type of victimization or violence. I will be talking a little bit about both. But one of the things that we have gotten wrong about this over the years is that we do often look for specific factors that are somehow going to help people. The metaphor that you often see in the resilience literature is like an umbrella. So an umbrella is something that is really only useful when it's raining, right? Otherwise, it's a pain to carry it around. Uh, and there's a lot of things that are kind of umbrellas in our world. So, orders of protection or rape crisis hotlines or things like that. They're very specific interventions that really aren't very useful unless you have experienced the specific problem of IPV or sexual victimization. But most of the things as Shiara's data, so compellingly showed, and so many other data sets have too, that many people have experienced many multiple types of violence. And the good news is that for the most part, we don't have to look exclusively or even predominantly for umbrellas. We can look for things that I like to call Swiss Army knives that are useful in lots of different situations and are going to help lots of us, no matter what our victimization or trauma paths have been, put together the pieces of a good life and however that means for us. So for meaning making, that's connecting to something larger than yourself. And there's extensive research that this is probably one of the most important things. It's kind of funny because it's often not very much emphasized in a lot of therapies, at least a lot of manualized therapies, but finding some kind of sense of purpose, whether it's dedication to a cause, like mine. And if I don't, I can not hope to presume too much, but I suspect for Shiara and Salime and many of the people on this call that working to reduce the global burden of violence and trauma is a mission that you are all dedicated to. It can be roles like teacher or parent. It can be religion or faith, as you guys put in the word cloud, culture or traditions, as Shiara was talking about. And, and even just finding ways to share a story, which is my favorite meaning-making intervention. But there's also some research, and a couple of my students have recently conducted some scoping reviews that I'll be drawing heavily on for these comments, that particularly for victims of sexual violence or intimate partner violence, that participating in social activism around those issues, like the Me Too movement, or organizations that promote gender equality or equity or victims' rights, are things that seem to be particularly helpful for people who've experienced IPV or SV. Um, One other domain that's a more individual set of assets are regulatory strengths. This is often where we focus on resilience work, and while it's not the only thing we need in our resilience portfolios, it is an important thing that we need in them. And this is just any kind of way we can find to manage our thoughts, emotions, and behaviors. And by far, the best way to do this in terms of existing scientific evidence is to engage in what I call breath and body work. This is also really important. One question I get asked a lot is how to deal with ongoing trauma. So if you're like a refugee or a stalking victim or something like that, some traumas don't have like a clear endpoint like a rape might have, but can be ongoing experiences for people. And so this is also one of the most powerful things you can do to help manage the long-term harm of chronic exposure to trauma, because it helps reduce what's called your allostatic load in terms of the scientific term, but that just basically means the wear and tear on your body caused by exposure to traumatic stress. um, Mindfulness, exercise. Again, the idea isn't that everybody needs the same package of breath and body work, but that the portfolio approach emphasizes that you can just try these different things and put together a combination that works for each of us or works for each of your clients. That may not be the same for all of them. um, interpersonal strengths. This is again getting back to the question of the social ecology, and really just to recognize that nobody heals alone, and that a lot of our work, especially I think in mainstream US culture, is very isolating and focused too much on individual healing when most of us really need relationships with others to thrive. Um, and I'll let you all, read some of these things now in the interest of time, but more specific to IPV and SV survivors can be connecting with people who've had similar experiences, knowing you're not alone, finding confidential sources of support, and especially on campus settings or places like that, finding places that you can disclose that are not going to lead to mandatory reporting or law enforcement reports or things like that. And this is also a place where sometimes formal support can be helpful too, although as Shiara's data showed, people in many other studies are much more likely to seek informal support, and I think we need to keep that in mind. And then our last domain is environmental resources like green spaces and blue spaces and built or human-made spaces. And in psychology, historically, we are not very good about recognizing the impact of the environment. But in fact, there's a lot of very strongly evidence-based nature interventions, and these are harder to screw up than a lot of other kinds of things like conventional psychotherapy and stuff, because a tree is almost always going to be a good thing in your life. And these are things I think we really need to start bringing in as a more of a focus uh, on healing and helping people heal and overcome past victimization experiences. In terms of specific effects for IPV or SV survivors, what we found really, again, is to think about safe spaces, and not just in terms of having safe people to talk to, which of course is hugely important, which came out of Salime's project too, with making sure that you are not getting negative or harmful responses. But there needs to be some physical settings for those safe conversations to happen. So there is that physical element of that too. And then also just thinking about ways that we can focus on women's rights and anti-violence messaging and things like that. So I think we need to invest more in terms of psychology and social work and places like that in thinking about these physical environments and what do we need to help people heal as well. And when we do that, we find that good stuff is much more important than bad stuff. We've found this now in 16 different samples. So it's not, this is just one data set, but you can see that even though, as Salimi and Shar and so many other researchers have shown, that your victimization does have an impact on your functioning, we have found over and over again that your portfolio of strengths actually has a much bigger impact on people's functioning. And I will end with that. I have, if you want to go to like the next Mentimeter, I'll put it over there, and you can sign up to stay connected with our community. And thanks very much for your attention.
Hey, so thank you so much to all of our wonderful panelists. And it looks like we have a few questions in the chat. Let's see here. I believe the first question, I think this came in when Dr. Salim was presenting her research. Did your study look into the gender of the perpetrators? If so, was there a disparity in your findings?
That is a great question. I did not specifically look at the gender of the perpetrator. What we do know from kind of like the national studies and the broader literature is that most of the perpetrators are kind of male when it comes to that. So I don't think I would have like the sample size with the smaller sample that I had to really be able to look at whether, the gender of the perpetrator or kind of whether having, multiple perpetrators could have impacted outcomes differently, but definitely a great future direction.
Okay. And it looks like our second question that came in, this was during Dr. Sabina's presentation. It said, how did you compute source demographic data among violence researchers? Oh, okay, it looks like you did answer, Dr. Sabina. Okay, you said that you didn't, just any research on the population would be interesting to see. The percentage of PhDs who are Latinos would be a proxy. Okay.
I think that question was in response to the slide that shows the under and over representation in that violence research. So that's just taking all violence research, like doing a psych info search with interpersonal violence or victimization, and then adding Latino to the search and seeing how much it goes down. So that's how I did that.
Okay, awesome, awesome. Okay. Well, it looks like we are about 4 minutes to one. I don't know if you guys want me to share contact information that I
A
can put in
question
the
just
chat to
came in.
everyone.
Yeah,
Oh, one question
and
just came in.
Sherry's answering.
Yeah, many of these things, Vicky Banyard and I recently wrote a book, or a couple of years ago, wrote a book called Strengths-Based Prevention. And many of the same things that help people heal from trauma are the same kinds of things that help them minimize their chances of getting involved in perpetration and or make them less vulnerable to victimization too. So I do think that shifting to a more strengths-based approach is definitely the way to get more effective with violence prevention, which our current violence prevention is not very effective at all. It has, I mean, many meta-analyses have shown that there's minimal impact if it's even measurable. And for example, a group did a meta-analysis of mindfulness on youth aggression a few years ago, and they found effect sizes that were in the D range of about 0.5, which is easily like 4 or 5 times higher than any of the standard manual like safe dates or anything like that, which take these much more cognitive and rational approaches to kind of being, oh, it's not nice to, to assault people. And, but, most kids, certainly most teenagers and college students like know that already. And the reason that these things are happening is not because of a lack of knowledge. It's because of uh, lack of regulatory skills and peer pressure and many toxic environments and things like that. And so we really need to target building up people's regulatory strengths, their healthy relationships, their sense of meaning and identity so that they are committed to values, anti-violence values in the same way we are, and in, healthier environments. And we are working on a paper now that focuses on prevention for IPV, and we are finding that basically very similar factors are reduce the likelihood of getting involved in perpetration.
Well, thank you so much, Dr. Hamby, for answering that. And we are getting ready to close up. We will share the contact information for all of our panelists. You can put that in an email um, to everyone who has attended. And I want to thank all of our wonderful panelists um, for just a wonderful discussion. I really appreciate everyone's input and thank you so much. Thank you for all the attendees. Hope everyone enjoys the rest of their day.
Thank you, Ebony. Thank you for organizing this.
No
Yes.
problem.
Thank you for the invitation and nice meeting you, Salime.
Yes, wonderful learning from you all too. Thank you.
Good to see you, Sherry. Take care.
Always. All
Bye.
right. Bye-bye.